So now we call Dr. Daraius. He is a famous active retina surgeon in New Delhi. And he will be talking about higher investigations as far as the inflammatory neovascular conditions are concerned.
Good afternoon, everyone. Thank you so much, Dr. Mele, for giving the kind invitation. It's amazing to be here. And I think my work has been made very easy by Dr. Manish and Dr. Abhijat because they've kind of set the pace and they've kind of given the groundwork and the basics. So now I'm basically going to show a lot of beautiful images and pictures. That's it. And then we can discuss them if you like. So when Sir says armamentum newer diagnosis, maybe I'll start in chronological order because ICG is what it's not really considered newer anymore. Unfortunately, people are using it less and less. So I just wanted to just show two cases where ICG really helped us. And then I'll move on to OPTOS, where wide field imaging is really opened our eyes literally. And then to OCTA. And OCTA is something where you can see wider also and deeper now with newer modalities, especially the swept source technique. So I'll cover all this briefly in my talk. So just want to start with a case. I'll not do too much theory. The 17-year-old girl who complained of blurred vision in left eye. What do you see in the fundus? I think it looks pretty normal. What do you see in the FA? I think it looks pretty normal. So your ICG helped us. So now look at the late stage ICG. Look at these spots which are seen in the late stage ICG. And very late FA you see some leakage. So this was a case of mutes. And in fact, there was a lot of discussion was done on this case, etc. And it was a self-resolving condition. So this kind of picked up the diagnosis and saved the girl from having to go through immunosuppressive therapy, multiple tests, etc. So it's important to know these diagnoses to kind of be able to manage the patient in a safe way. Second case, this was a patient who came for a second opinion with drop of vision in right eye, blurred vision right eye. FFA montage, it looks pretty normal. I think everybody would agree. But you can see the dropouts in the ICG angiography. So this was a case again, of course, managed by Dr. Shishir, who is my hero for inflammation, and started on oral steroids, and thick choroid could also be seen on the EDI OCT. So this I just wanted to kind of tip of the ISO, but I think ICG is no longer new. We have much newer kids on the block, like ultra wide field angiography, OPTOS imaging, and my favorite, the dye-less OCT angiography, where wide field OCT has broadened our horizon in a non-invasive manner. So this is traditional 30 degrees. You go wider with the ETDR7 field. With ultra wide field, you're almost seeing 200 degrees with the OPTOS. And these are just cases, I think we don't need to go details, just been discussed by Dr. Abhijat. The inflammatory CRVO, where you beautifully see ischemia and cutoff zones, it's all delineated. And you see how posterior the ischemic area is coming and encroaching and threatening the macula in this case. Similarly, a superior temporal inflammatory BRVO, where you can see some laser marks which I think need to be tightened, and beautiful collaterals which are forming, you can see in this image. So of course these you always need to look for any primary cause. Take your friend's help, a physician, cardiologist, rheumatologist, laser promptly. This is just what we discussed, the controversy, whether you do it only after we see neovascularization, or like I agree with Dr. Abhijat, supposing patient is not able to come for follow-up very much, or you're seeing the progression is very rapid, you may consider doing a PRP laser, and you just treat the areas which are affected. You can spare the normal areas at that time. And I think they work very well. A combo therapy with anti-VEGF or steroid followed by laser works very, very well. Patients, especially where they have even tiny amount of macular edema. Even if you see a tiny speck, I think do the combo therapy. If you only do laser, then they come back with the edema and then they blame your laser for it. So I think this is some small tip I would like to say. Now what about non-dilating pupil? This is where I think the wide field, the new armamentarium is beautiful, because here you see on the right side and the left side. On left side, through the small pupil, you can get a FFA of course, but you may not be able to see the zone, you may not be able to make out where exactly to laser. But here if you see, in the wide field, it's all seen in one picture. And how simple your laser is after that. You can see the nasal areas of CN neovascularization, you can target it, you can do a targeted retinal laser in using the wide field newer technology. Uveitis, so you can see how beautifully the pars planitis has been picked up using this OPTOS picture. And right up to the pars, you can see the cotton ball exudates in this patient right at the snow banking, which is seen beautifully. And another case, where we can see NVE at the pars plana. So in fact, the ultra wide field FFA has replaced FFO, which we used to do in our fellowship, the fundus fluorescent ophthalmoscopy. That has been replaced by doing a wide field imaging. This is other interesting thing which we just spoke, Dr. Malaya, so where we can do something like treat and spare. If we see well where the areas are affected, you don't really have to go after the normal retina. You can treat and spare. Diabetics generally I don't follow this, but vasculitis cases, this is some of the cases we do this. We just treat the areas which are affected. Now what about OCTA? So basically OCT angiography, the basic concept is in a static eye, the only moving structure in the fundus is the blood, the RBCs which are flowing through the vessel. And the advantage is you can get depth resolved. So you can see layer by layer vascular layers, and then you can kind of zone in on the area of interest. When you have a combo of swept source plus OCTA, you have a winning combination where you can go wider up to 16 millimeters and deeper 3 millimeters depth. So these are the kind of montages we see. We of course have the classic 3x3 image which is right in the center, but we're going wider, doing 15x9, and when we stitch all these together we get a 22 by 22 mm kind of image. And these are the kind of images which really help us see everything without a dye. So just one or two cases. This was a patient who had a superior temple BRVO with NVE. Laser was done long way back in 2007. So you can see on the imaging, you can see the sclerosed vessel, the laser done. And this is what I was talking about, slicing. So you can see the NV which is raised. So only in a particular slab, if you cut the slab, you see that which is the VR interface. So that's one of the higher slabs. As you go lower, you go to retina surface, you can go down to choroid. So here you can see it beautifully on this wide field slab. And over 13 years, she had a bleed. Vision remains 6A. So a message from here is just less is more, because there's traction. We were avoiding anti-VEGF. We just observed this patient, but it's good to know what's going on. Second patient is a known case of CML. TLC was only 1.8 lakhs. So you can make out patient is a sick patient. Left eye vision has gone down to 660. Pressure is high. Both eyes ischemic CRVO with neovascular glaucoma in the left eye. NVI is noted on the slit lamp exam. A very featureless retina you can see in the right eye. And the left eye also you can see how much ischemia there is, and some CME in the left eye, which is the poor vision eye. And here I want to show how beautifully, if you have a wide field OCT angio, right up to the periphery, you're able to kind of make out this massive amount of CNP areas in this patient. So of course the patient was put on anti-glaucoma treatment, anti-VEGF, and a tight laser was done, and a DLCP in the left eye. So I'd like to conclude with a mystery one-eyed case. This was a young man who complained of blurred vision, and this was one-eyed because right eye was lost to trauma. So we were wondering whether it's because of some inflammatory thing. Is there something sympathetic happening, sympathetic ophthalmia? But no, it wasn't. And these are the kind of images you can make out the stasis, you can make out the dilated tortuous vessel. And then we got the hemoglobin done, something very simple. Hemoglobin was 17, which is not very common in our population. And when the literature search, one of our fellows was very enthused about it. So they did a PCR for this JAK2 mutation. And then venesection was done for 2 units of blood. And after therapy, patient improved to 6/5. So sometimes these rare things can come which mimic inflammation, neovascularization. And they just need a simple hemoglobin test to diagnose it. So I'd like to conclude. I think today we have discussed the newer imaging modalities, starting with ICGA, which is not so new anymore. We moved on to OPTOS, OCTA, which helps us see deeper and wider. And all these tools are a whole new world for managing our cases. So I'd like to thank the entire team at Shroff Center, and for Sir, a special photograph of Dr. JB looking very, very young. And with him, I don't know how many people can recognize Dr. Shishir, because they are my uvea guru. As far as possible, I stay very far away from uveitic cases because I have luxury of referring to Dr. Shishir. But whenever I don't, or he's away, then I have to kind of take the help of my 2 gurus. Thank you so much.
Thank you, Daraius. For those who are not aware of the word MEDWS, mutes, it is multiple evanescent white dot syndrome. One thing which you said about if you have a small edema, you will do injection and laser also. What is your take? Why not only injection? That's the question.
So, if there's a small amount of edema and the patient has got any NVD or NVE, then I will do the combo. But if there's mild or moderate NPDR or mild NPDR with only edema, I'll only give the injection.
Great. Okay, fine. And you also showed some fantastic images of 22 by 22 octa.
Yes, sir. Yes.
How difficult it is to do it?
So yeah, you need cooperative patient, you need a lot of time, and you need a fantastic machine like a Plex Elite. So I think all those boxes, if we tick, we can get that image.
Okay. So thank you, Daraius, for